Everyone, I am Dr. Moumita Biswas. I am working as a pediatrician in a government hospital of West Bengal. Today's topic is on CPAP versus HFNC in newborn. As we all know that preterm birth is the leading cause of neonatal morbidity and mortality worldwide. Respiratory failure, which is the most important cause of neonatal mortality, is more common in preterm than term infant. There is increased survival because of advances in respiratory support and surfactant therapy. Though invasive ventilation is life-saving, in its goal to ensure adequate oxygenation and ventilation, it often results in secondary lung damage. That's why approach has been shifted towards a gentle lung protective non-invasive ventilation. Now what is NIV? NIV referred to support provided to the nasal airway opening of a spontaneously breathing infant in absence of an endotracheal tube. There are various modalities of NIV and CPAP is the most commonly used one. NIV mitigates lung injury and emerges as an alternative approach to invasive ventilation. Though CPAP is a well-established mode of NIV, it has various potential disadvantages, like it requires bulky interfaces, requires highly skilled nursing care, can cause nasal trauma, air leaks, and CPAP belly. All these drawbacks force to look for alternative respiratory support. During this time, HFNC came into the picture, which is a small, thin, tapered binasal tube. It delivers blended air and oxygen mixture heated at 37 degrees centigrade with 100% humidity at gas flow of more than 2 liters per minute. The main disadvantages of HFNC is it delivers variable descending pressure. So why is the need of HFNC over CPAP? It is simple to use. It can cause less nasal trauma and gastric distension. Easy to carry out KMC, preferred by caregiver as well as parents, and it is well tolerated in newborn. As depicted in the picture, HFNC has only one limb, that is the inspiratory limb, and the nasal interface should cover only 50% of the nasal orifice so that baby can easily breathe out along the nasal prong. Whereas in CPAP, both inspiratory and expiratory limbs are there and nasal interface should snugly fit the nasal orifice. So to choose in between CPAP and HFNC as better respiratory support, we have to assess each of the entity on the basis of primary respiratory support, post-extubation support, and weaning modalities. For this purpose, we have to know the outcome of various clinical trials done so far. The first one is the HIPSTAR trial, which was done in 2016. It is a multi-center non-inferiority randomized control trial, including 564 preterm infant of gestational age of 28 weeks to 36 weeks 6 days of less than 24 hours old. Trial stopped early due to safety concern. The primary outcome as treatment failure within 72 hours was significantly higher in HFNC group, where it was 25.5% versus CPAP group, where it was only 13.3%. So the conclusion was HFNC was worse than CPAP regarding primary respiratory support. Then came that Hunter trial, which was published in 2019 in New England Journal of Medicine. It included relatively larger newborn. Here again, HFNC had higher incidence of treatment failure than CPAP as early respiratory support. A retrospective study done by Taha and colleagues in 2016, including more than 2,000 infants, shows that HFNC was associated with increased respiratory morbidities, delayed oral feeding, and prolonged hospitalization. Whereas a non-inferiority randomized control trial done by S. Murki and colleagues in 2018 also concluded in the similar way. This is a meta-analysis including 7 trials with total 1,833 preterm revealed that as early respiratory support, HFNC had higher treatment failure than CPAP, whereas there was no difference in rate of mechanical ventilation within 72 hours. The recent meta-analysis, which was published in 2023 in Cochrane database, also concluded that high flow likely caused more treatment failure than CPAP within 72 hours, but it can cause less nasal trauma. There was less evidence for use of high flow as primary respiratory support in preterm infant of less than 28 weeks. Now the studies which I have discussed so far basically focused on primary respiratory support. Now come to the post-extubation support. This is a pooled analysis of high flow versus CPAP as post-extubation respiratory support, including 8 trials with total 1,039 preterm. The data revealed that HFNC showed no statistically significant difference in treatment failure and reintubation compared to CPAP. Manley and colleagues reported a very high treatment failure with high flow group in infant less than 26 weeks of gestational age. Whereas in Cochrane review, which was published in 2016, it was reported that high flow can cause less nasal trauma than CPAP. The recent systemic review and meta-analysis, which was published in 2020, also concluded that HFNC is non-inferior to CPAP as post-extubation respiratory support in preterm of gestational age of 28 weeks to 32 weeks. Another systemic review and meta-analysis, which was published in 2022 in Turkish Archive of Pediatrics, also reported that HFNC may be as effective and safe as CPAP. There was similar extubation failure and risk of air leak syndrome, pneumothorax, and BPD, though further studies are needed to establish the efficacy in lower gestational age group. Regarding cardiorespiratory behavior, a crossover study was published in 2020, which shows that HFNC was associated with longer respiratory pause and higher FiO2 requirement in extremely preterm infant shortly after extubation. There are various conflicting evidence regarding weaning from different RCTs. According to Yoder and colleagues in 2023, HFNC requires prolonged respiratory support than CPAP. Whereas Abdul Hadi and colleagues in 2011 concluded that weaning preterm infant from nasal CPAP to HFNC is associated with longer duration of oxygen and respiratory support compared with infant remained on CPAP until weaned directly to room air. Whereas in CHIEF study in 2023, it was found that weaning from CPAP using HFNC was non-inferior to weaning from CPAP alone in stable, very preterm infant. So it may be viewed as an alternative to CPAP in those infants who require prolonged respiratory support. Regarding term infant, there was little or no difference in treatment failure, but HFNC reduced the incidence of nasal trauma and abdominal distension. So to summarize, nasal CPAP is recommended to use as primary respiratory support in preterm infant with respiratory distress. HFNC, although less effective than CPAP as primary support, may be used in infant of more than or equal to 30 weeks of gestational age with FiO2 requirement of less than 30% as primary respiratory modalities. HFNC is non-inferior to CPAP as post-extubation support in preterm infant of more than 28 weeks, although caution is recommended in using it in this high-risk population due to paucity of data. Rescue CPAP should be available during both primary and post-extubation use of HFNC to prevent reintubation. HFNC may be used in infant with nasal trauma depending on their clinical stability. However, CPAP is more cost-effective than HFNC as primary respiratory modality. So the take-home messages are, modern era is the era of non-invasive respiratory support. CPAP and HFNC both can provide good quality of non-invasive respiratory support, but both should be used judiciously according to the clinical condition of the baby to get optimum clinical advantages with minimum adverse outcome. Thank you.
Thank you. Excellent presentation, quite evidence-based summary. We have discussed most of these in the PCS as well as in the earlier lecture, but this is just to make it clear that there are certain situations where high flow is clearly used and some situations where you prefer CPAP or NIPPV. So now we can open it up for questions. Anyone has questions or comments, please, or you can share your experience. Dr. Avneet is saying brief and informative. Good. So do you have any comments, Dr. Avneet, from your own experience?
Sir, we are using CPAP only. Most of the times we are using CPAP only. And
you have high flow?
Yes, sir, we have high flow facial impactor. But most of the times we are 90% we are using CPAP only.
And the interface you are using for CPAP is?
We are using DAMS cannula.
Okay, so as we discussed in the PCS, I mean, the main advantage that we purported for high flow was the ease of handling. And now with the RAM cannula for CPAP or NIPPV, you can be flexible with the pressure support. At the same time, the ease of care comes with that itself. So one of the major advantages that we had for high flow is no longer there when we start using an interface like RAM cannula. So obviously we discussed RAM cannula and its disadvantages as well. So
Yes.
I think you may use a little more pressure than you would otherwise with a normal interface, but it works and you can titrate it to the baby's needs. Dr.
Yes.
Barfi, you had some comment?
So for us, we are mostly using HFNC. We have CPAP. We have just acquired CPAP machines, and we've started using them also.
And you have the RAM cannula similar interface?
No, so we don't have RAM cannula. We are a very low resource setting, so we are procuring, sir, but not yet received.
CPAP, what interface you're using? The one that comes with the device?
So the Fisher-Paykel one, the binasal prong, and the mask as well. Yes, sir. The one.
Yeah, so the RAM cannula can be used with other bubble CPAP-like devices as well. So you do have the advantage of going higher on the pressures. So what flow do you set on the bubble CPAP? Do you use 6 liters to start with and then titrate, or?
Yes, around 6 to 8 liters.
Yeah. So, Dr. Payal?
Sir, we have only CPAP. We don't have HFNC in unit. We are using only CPAP.
So the OptiFlow that comes from Fisher-Paykel, I mean, if you have a blender already, you have standalone blenders, right?
Yes, sir.
So you have the blender, you have the humidifier, which is the same. So you just need the circuits. So if you contact the team, they will be able to guide you.
Okay.
So obviously it's not going to make a huge difference, but if you don't have RAM cannula, for example, or if you have shortage of your bubble CPAP devices, if you're in a busy unit, it gives you alternative options. Because Moumita, you mentioned about some studies showing a longer duration. So we used to experience that as well, but we don't see that as often these days because we are trying to wean quicker. So we used to go step by step, but now we don't go rigorous guidelines to wean. So we can start weaning and the nurses titrate how quickly they wean. As long as the baby is tolerating, every 4 to 6 hours, they can wean 0.5 liters, or in bigger babies, even faster. And once they reach 2 liters, for example, some of us stop at 3 liters and you can wean down to 2 liters and then remove it. But the slow weaning is not used much unless the baby is really preterm. We discussed that for a 28 weeks and below, you keep them till 32 weeks on some form of positive pressure. Meera, good evening. Do you have any comments on what you use in your unit? I think you're on mute, Meera. Anyone else wants to comment? Dr. Ajeshwar, Dr. Janika? Any questions? I think we have had a few discussions on CPAP, so I think everyone is clear about the concepts, and this is a most commonly used modality as well.